We have studied the ECG manifestations resulting from damage to different components of the conducting system in videos spread throughout this course. We will now briefly review the ECG diagnosis of conducting system abnormalities. Damage to the AV node or diffuse damage to multiple components on the right and left sides of the intraventricular conducting system impairs the transmission of atrial depolarization into the ventricular myocardium, manifesting as AV block on the ECG. AV block may be first, second or third degree. Isolated damage to the main body of fibres in one of the branches of the bundle of His results in left or right bundle branch block on the ECG. The PR interval is normal as depolarization is initiated in good time on the unaffected side of the heart. However, the QRS complexes are wide as depolarization travels slowly through the affected chamber outside the conducting system. The ECG patterns produced by left, or as shown here, right bundle branch block are predictable and distinctive. However, in the majority of individuals, the left bundle branch divides into three peripheral branches or fascicles. The two major subdivisions of the left bundle branch, the left anterior fascicle and the left posterior fascicle, depolarize the walls of the left ventricle. Because of extensive anastomoses between these systems within the walls of the left ventricle, when one of these major branches is damaged, the QRS complex duration remains within the normal range. However, the altered pattern of flow within the left ventricular wall manifests on the ECG as a shift in the cardiac axis. Left anterior fascicular block results in left axis deviation, while the more unusual left posterior fascicular block results in right axis deviation. As outlined in earlier videos, damage to components of the conducting system occurs secondary to many different pathologies. However, you will commonly encounter conducting system dysfunction in the setting of ischemic heart disease, and therefore it is worth knowing a little bit about the blood supply of the conducting tissues. As shown here, the AV node is usually supplied by a branch of the posterior descending artery, which is itself a branch of the right coronary artery in 90% of individuals. In clinical practice, AV node damage with first, second or third degree AV block is often a problem in inferior infarction or ischemia secondary to obstruction of the right coronary artery. The left anterior descending artery supplies the interventricular septum through septal branches. These vessels supply the right bundle branch, the main body of the left bundle branch and the left anterior fascicle of the left bundle branch. Anterior myocardial infarction may therefore result in blockage of conduction in either the right or left bundle branches, resulting in new onset right or left bundle branch block on the ECG, while left anterior fascicular block developing in anterior MI will give rise to left axis deviation on the ECG. In very extensive anterior infarction resulting from obstruction of the left anterior descending artery proximal to the origin of the septal branches, both the right and left side of the intraventricular conducting system may be damaged, resulting in AV block on the ECG, a very poor prognostic sign in anterior MI.